Hello everybody, welcome to my talk on the wrist, bone, and ligamentous injuries. I'm McCarthy, I am this year's hand fellow. So to start off, I'll have these pictures interspersed just to try and break up the talk. I find them funny, hopefully you do too. So the objectives of our talk are to talk about the anatomy and kinematics of the wrist, followed by carpal bone fractures. We'll touch on Kienbock's and Preiser's disease, and then look at the ligamentous injuries of the wrist. So first is anatomy and kinematics. When we're looking at the wrist, we'll start with the bony architecture. It is a complex composite joint of 20 different articulations formed by 15 different bones. The bones are all labeled here, but it's radius and ulna, followed distally by the 8 carpal bones and 5 metacarpal bones. Load is transferred distally 80% through the radius and 20% through the ulna when it is a normal or neutral alignment. When the ulna is longer than the radius, it increases the load that the ulna is seeing, and opposite, if the ulna is shortened, it decreases the load that the ulna is seeing. For planes of motion of the wrist, there are 3 axes of motion: flexion and extension, radial and ulnar deviation, and pronation and supination. I have listed the normal ranges of motion for each of these axes. Here are just some pictures further specifying what those axes of motion are. Looking at the carpal bones specifically, they are arranged in a proximal row, which is comprised of the scaphoid, lunate, triquetrum, and the distal row, which is the trapezium, trapezoid, capitate, hamate, and then the pisiform is a sesamoid bone. Everybody has different ways that they remember the location of these bones. The 2 that I have used most frequently are so long to pinky, here comes the thumb, or some lovers try positions that they can't handle. Whichever one sticks in your mind best, feel free to use. Now we'll specifically focus on the movement of the scaphoid, which is the keystone of the carpal bones. The scaphoid has a natural inclination to flex. You can increase the scaphoid flexion with wrist flexion or radial deviation, and extend the scaphoid with wrist extension or ulnar deviation. Looking at the dart thrower's motion, this will be a motion that maintains the scaphoid and the lunate in a neutral position. You begin with your wrist extended and radially deviated. Those positions neutralize the scaphoid because radial deviation makes the scaphoid want to flex, while wrist extension makes the scaphoid want to extend. And then at the end of motion, you are in ulnar deviation and wrist flexion. Again, those neutralize each other because wrist flexion makes the scaphoid want to flex, and ulnar deviation makes the scaphoid want to extend. I thought this was a nice x-ray that further helped delineate each carpal bone, because I know it's tricky when you're looking at x-rays trying to pick out the overlying cortices of the different carpal entities. And again, this is looking at the x-ray from a lateral position. I think the key things to note here are looking at the relationship of the capitate, lunate, and the distal radius. That should be one single line. And then on the volar surface, it's just a matter of looking at a lot of these x-rays so you can get better and better at tracing out each carpal bone and looking at their relationship with each other. And I thought this image did a nice job of a normal x-ray and indicating what those bones should be looking like. Here's another nice little break slide for you. Means we're making progress. We'll now discuss the ligaments of the wrist. We will talk about both the extracapsular and intracapsular ligaments. And within the intracapsular ligaments, we will break it down to both the extrinsic and the intrinsic ligaments. I thought this image did a nice job of just simplifying some of the ligamentous entities we will go on to discuss. Moving beyond the color block format of the prior image, these images are included so that you have more of a visualization of what these ligaments would look like in real life and how they do, in many ways, just become a confluence of ligaments, and it's important then to try and look at the fibers traversing pattern to help distinguish the ligaments from each other. Now we'll start to discuss the different entities that comprise the extracapsular and the intracapsular wrist ligaments. The extracapsular wrist ligaments are comprised of the transverse carpal ligament, the piezohamate ligament, and the piezometacarpal ligament. The intracapsular ligaments are the ones I think we most commonly associate with our wrist pathologies, and they are the extrinsic ligaments, which bridge the carpal bones to either the radius/ulna or metacarpals, and the intrinsic ligaments, which originate and insert on the carpal bones. Of clinical importance when discussing the ligaments of the wrist is the space of Poirier, which lies between the volar radioscaphocapitate and the long radiolunate ligaments. I think this cadaveric image here does a nice job of depicting this space. The radioscaphocapitate ligament is distracted by the retractor and allows for exposure of that potential space. Again, the space lies between the radioscaphocapitate and the long radiolunate ligaments. It is of importance during perilunate dislocations as it allows the distal carpal row to separate from the lunate through this space, and during lunate dislocations because the lunate escapes through this space. Now we'll begin discussing the ligaments which make up each of these entities. To begin, we'll discuss the extrinsic ligaments, which are comprised of the volar radiocarpal ligaments, the volar ulnocarpal ligaments, and the dorsal ligaments. Here is a list of each of those entities. This picture does not depict all of the previously listed palmar and dorsal extrinsic ligaments, but it does highlight those that are of more clinical importance. Specifically, on the volar surface, the radioscaphocapitate ligament and the long radiolunate ligament, which help define the space of Poirier that we had talked about earlier, is of importance with perilunate and lunate dislocations. You'll also hear discussed in surgeries the importance of maintaining the radioscaphocapitate ligament when you are performing a proximal row carpectomy because it helps prevent ulnar drift postoperatively. And then looking on the dorsal surface, I've most often heard people talk about the dorsal intercarpal ligament when we are going to reconstruct the SL ligament following an acute injury. The next couple slides will be focused on reinforcing particular ligaments and their clinical importance and their appearance on different imaging modalities. Here is the radial collateral ligament, and the handy arrows have indicated its origin on the radius and its insertion on the scaphoid. Next is the radioscaphocapitate ligament. It is a sling to support the waist of the scaphoid. Some clinical correlates, as previously mentioned, it is critical to preserve during a proximal row carpectomy as it is the primary stabilizer of the wrist after a PRC and prevents the ulnar drift. It is important that when you are performing a radial styloidectomy, such as in the setting of radioscaphoid arthritis, that you do not resect greater than 4 millimeters, or you may disrupt the origin of the radioscaphocapitate ligament. Additionally, when thinking about scaphoid fractures, oftentimes they break at the waist, and part of that predisposition is due to the location of the radioscaphocapitate ligament acting as a sling supporting the scaphoid waist. Now we'll talk about the long radiolunate and the short radiolunate ligaments. The long radiolunate is the more radially based ligament. The short radiolunate is more ulnar in comparison. The long radiolunate ligament is abnormal in a Madelung's deformity and is most often referred to as the Vickers ligament in that setting. And the short radiolunate is a key stabilizer of the lunate and is one to think about with a perilunate dislocation when the lunate stays reduced in the lunate fossa. The radioscapholunate is often a ligament that you see on these diagrams. However, it is not a true ligament. It does not add any mechanical strength. Its primary function is as a neurovascular conduit. The next two slides will depict the ulnotriquetral ligament and the ulnolunate ligament. Both originate on the ulna and insert on their respective carpal bones. Again, just demonstrating the ulnolunate ligament. This will be our final slide on extrinsic ligaments. The radiotriquetral ligament, otherwise known as the dorsal radiocarpal ligament, is critical with formation of the DISI deformity. We initially think of the disruption of the lunotriquetral interosseous ligament. However, you must keep in mind that in order for the DISI deformity to occur, the dorsal radiocarpal ligament must be disrupted as well. And finally, the dorsal intercarpal ligament is this more transverse entity, and I most often hear that discussed when talking about repair of SL ligament injuries. Now to discuss intrinsic ligaments. Again, intrinsic ligaments are those that bridge between carpal bones. Here is a list of the intrinsic ligaments. The following slides will go into further detail. The scapholunate ligament is comprised of three components. The dorsal is the thickest and strongest, preventing translation. Volar prevents rotation and proximally has no true significant strength. When thinking about disruption of the scapholunate ligament, it's important to remember that the scaphoid has a natural desire to flex. So when the scapholunate ligament is disrupted, the scaphoid will flex. The lunate, since it is no longer tied to the scaphoid, will then follow the triquetrum, which has a natural desire to extend, which leads to the development of the DISI deformity, which involves lunate extension and scaphoid flexion. The lunotriquetral ligament is also comprised of three components. Again, the dorsal, volar, and proximal. Unlike the scapholunate, where the dorsal component is the strongest, for the lunotriquetral ligament, the volar component is the strongest. Disruption of the lunotriquetral ligament allows the lunate to continue to follow the scaphoid, which will lead it into a flexed position, while the triquetrum will fall back into its desired extended position, leading to a VC deformity. Again, important to remember, in order for the VC deformity to occur, not only does the lunotriquetral ligament have to be ruptured, but there also has to be a rupture of the dorsal radiotriquetral ligament. Next, we'll address the physical examination for the wrist. I will not address all of the provocative maneuvers available, but I will highlight a few for us to discuss. A key component of the wrist examination is an understanding of your bony landmarks. These images helped depict the approximate location of different palpable entities within the wrist. To begin is the Watson shift, which is a provocative maneuver to assess the SL ligament. This image helps depict how this maneuver is supposed to be done. We'll just walk through it. The wrist is supposed to be moved from an ulnar to a radially deviated position. During this motion, pressure is applied by the examiner's thumb to resist scaphoid flexion, because again, the scaphoid is extended with ulnar deviation and flexed with radial deviation. So as they're moving into radial deviation and the examiner is placing pressure against the scaphoid, you are helping resist the scaphoid's flexion. And while you're palpating, as they're transitioning from ulnar to radial deviation, you may be able to feel a subluxation of that scaphoid, indicating disruption of the SL ligament, or the patient may have pain during that maneuver. The ballottement or LT shuck test is a lunotriquetral provocative maneuver. It's performed by grasping the lunate between the thumb and index of one hand and applying an alternating dorsal and volar load across the triquetrum, utilizing the thumb and index finger of the other hand. A positive test would be indicated by pain, crepitus, or increased laxity. The Kleinman's shear test is a second provocative maneuver for the lunotriquetral ligament. It is performed by stabilizing the radiolunate joint with the forearm in a neutral rotation and utilizing your contralateral hand to load the triquetrum in the anterior to posterior plane, producing a shear across the lunotriquetral joint. Again, a positive test would be indicated by pain or a palpable clunk with motion. I know that wasn't all of the provocative maneuvers that can be performed for evaluation of the wrist. However, I think going into that detail gets a little into the weeds, and I think it's important to remember that the wrist, once you get a better understanding of the palpable bony landmarks, you can really localize a patient's pain and then try and elicit that entity as the underlying etiology of their discomfort. Again, this is just another slide to break up the talk. I find them funny. On to imaging. You want to have a minimum of 3 views of the wrist. The views that you will get will vary depending on what you think the underlying diagnosis is. First thing to look at when viewing the wrist in the PA or AP plane is look for Galula's lines. Here they are indicated in colors. That should be your first tip-off if there is a break in the Galula line, that there is something occurring within the carpal bones. For advanced imaging, you can get the whole spectrum, whether it be a CT, an MRI, or jumping ahead for arthroscopy to get a direct visualization. Looking at carpal, we'll start with scaphoid fractures. The scaphoid is the largest bone in the proximal row. Greater than 75% of its surface is covered by articular cartilage. Its major blood supplies from the dorsal carpal branch of the radial artery. That artery provides the proximal 80% of the scaphoid in a retrograde flow, and it has a minor contribution from the superficial palmar arch, which supplies the distal 20% of the scaphoid. It's important to know the blood supply to the scaphoid due to the increased risk of avascular necrosis with scaphoid fractures. The incidence of AVN is directly correlated with the proximity of the fracture to the proximal pole. Proximal third scaphoid fractures have an AVN rate of 33%, while proximal fifth fractures have an AVN rate of 100%. These images just further depict the surface anatomy of the scaphoid and its different articulations. I think it's important to try and develop an understanding of the shape of the different carpal bones, particularly when going into surgery, as we often are pinning these, and the better you understand the anatomy you're dealing with, the more likely you're able to look good when trying to put a K-wire across one of these. So scaphoid fractures, they're the most injured carpal bone. They account for 60 to 70% of all carpal bone fractures. The anatomy of the fractures Part of it is due to that radioscaphocapitate ligament. As we had previously mentioned, it acts as a fulcrum. Because of that ligament and its location, that is why the waist is the most common location for fracture, followed by the proximal third and then the distal third. Historically, we thought that distal third scaphoid fractures were more common in pediatrics. However, that has recently changed, and waist fractures have become the most common. One of the thoughts is that maybe with our increasing size of our children, that's why we're seeing more scaphoid waist fractures, but it is not yet clear. A common mechanism for fracture is an axial load across a hyperdorsiflexed, pronated, and ulnarly deviated wrist. When viewing for these fractures, you want to make sure that you get a scaphoid view. So you'll have the fingers flexed, and then the wrist extended and ulnarly deviated. Both ulnar deviation and wrist extension bring the scaphoid into extension and will allow you to see along the body of the scaphoid, or you can do a clenched fist view. I think that's best utilized to see if there's an associated SL ligament disruption. For further imaging, you can obtain either a CT or an MRI. The CT is the best modality to evaluate for fracture location, angulation, displacement, or look for assessing the bony union or lack thereof. An MRI is the most sensitive for diagnosing occult fractures and helps to assess the vascular status of the bone, particularly when a proximal pole fracture is being evaluated. Management options. Non-operative management is indicated for non-displaced fractures. It needs to be less than 1 millimeter of displacement. In the setting of less than 1 millimeter of displacement, we have a 90% union rate with non-operative management. Essentially, the only time you're going to run across a scaphoid fracture that fits this criteria is one that is not visible on X-ray, but can be seen with advanced imaging. Surgical indications are much more frequently encountered. That's displacement of the fracture, anything greater than 1 millimeter, having a humpback deformity, evidence of a DISI deformity but without associated arthritic changes, fractures in the setting of a dislocation, delayed presentation, a proximal pole fracture where you're at increased risk for AVN. How do we take care of these? You can either do a percutaneous screw fixation versus an open reduction and internal fixation. They can be approached from a dorsal or a volar manner. Dorsal approaches are best suited for proximal pole fractures. The key there is to avoid the EPL tendon and preserve the blood supply that's entering along the dorsal ridge of the scaphoid. With a dorsal approach, there is a higher risk of having unrecognized screw penetration of the subchondral bone. Or you can approach volarly, that is best suited for waist or distal pole fractures, also utilized more commonly in humpback deformities. It allows for preservation of that dorsal blood supply, and its approach is developing the interval between the FCR and the radial artery. Here are some pictures depicting the dorsal approach. Again, the key for a dorsal approach, or any approach rather, is that if you're going to be doing this screw fixation, you need to have center placement in order to maintain maximum stability of that fracture fragment and get appropriate compression across the fracture line. These are some images depicting the volar approach. Again, you can palpate that scaphoid tubercle volarly, and you want to develop between the radial artery and the FCR tendon. As you'll see in this top right, they have the FCR retracted ulnarly and the radial artery retracted radially. That brings us down to the radioscaphocapitate ligament. Again, just to remind us of that clinical correlate, that is an essential ligament to maintain when performing a PRC. because that is the stabilizer of the wrist and prevents ulnar deviation. It's also critical to remember that structure when performing a radial styloidectomy. You do not want to resect greater than 4 millimeters of that radial styloid for fear of compromising the origin of the RSC ligament. And then that final image depicts retraction of your ligamentous complex and allowing for exposure of that distal pole. So the keys to fixation for any type of bone healing is you need viable bone cells, an adequate blood supply, and stabilization of the fracture. This is just showing the technique utilized for these percutaneous screws and developing compression across the fracture site. You're seeing the difference in the pitch of the initial threads versus the threads associated with the head, which allow for compression of the fracture fragment pieces. Again, the viable bone cells are essential, adequate blood supply, most concerning with our proximal pole fractures, and you need to have best stabilization of the fracture, which is more likely to be achieved with center-center positioning of that screw. Complications associated with scaphoid fractures are non-union, osteonecrosis, which occurs in 13 to 50% of all scaphoid fractures, malunion. The malunion most commonly discussed is the humpback deformity, which is flexion of the distal fragment and extension of the proximal fragment due to the pull of the SL ligament. You can have subchondral bone penetration of the screw. That's more commonly encountered with a dorsal approach, or you can have development of a SNAC wrist, which is a scaphoid non-union. So non-union risk factors are delay in presentation, having a proximal pole fracture due to the retrograde blood flow to the scaphoid, increased displacement, advancing age, associated instability, or nicotine use. To the right is a table just indicating an algorithm for how to treat different scaphoid non-unions based upon what their underlying issue is. If it's a delayed union, if it's a humpback non-union, if it's a proximal pole entity. If a non-union of the scaphoid has been encountered, then it's important to understand the next step, and that would be consideration of our bone graft options. The next couple slides will just detail what those options are. I won't go into the nitty-gritties of surgery for each of those. Again, I just think you can really get in the weeds of that, and it's more important to understand that we do have a variety of options available. So to begin, we'll discuss the corticocancellous radius graft. That is, as it sounds like, you're obtaining a cortex and a cancellous portion of the distal radius, harvesting that, and then transposing it into the scaphoid fracture in order to improve the length and alignment of that scaphoid. Following, you're going to be utilizing a screw not only through the fracture fragment pieces, but the graft as well to hold that all in position. The next step in the bone graft ladder is talking about a vascularized pedicle bone flap. We have 3 arteries that are most commonly used for our pedicled bone flaps. They are the 1-2 intercompartmental supraretinacular artery and the 2-3 intercompartmental supraretinacular artery, and finally the volar carpal artery. The image on the right displays the different trajectories of those aforementioned arteries. Finally, if you are looking for a remote location to transfer to the scaphoid, 2 considerations are the iliac crest, which is based upon the deep circumflex iliac artery, or the medial femoral condyle flap, which is based upon the descending geniculate artery. When looking through these graft options, specifically if you're going to be looking remotely, the most success for management of these scaphoid non-unions has been demonstrated with the medial femoral condyle flap. If a scaphoid non-union is not identified in time and it goes on to develop associated arthritic changes, that is referred to as a SNAC, scaphoid non-union advanced collapsed wrist. Below are images depicting the radiographic classification of the SNAC wrist. Stage 1 is localized to the radial side of the scaphoid and the radial styloid. Stage 2 includes stage 1 plus involvement of the scaphocapitate, and stage 3 builds upon stage 2 by having periscaphoid arthrosis, which is more diffuse arthritis about. There is occasionally preservation of the proximal lunate and capitate. SNAC wrist treatment is based upon symptoms. Like any arthritic entity, just because I see it on an x-ray does not mean the patient is bothered by it. If you note it on the x-ray and the patient is not sufficiently symptomatic, then the treatment modality would be observation. If they are sufficiently symptomatic and have been deemed surgical candidates, the treatment options are dependent upon their stage of SNAC wrist. Stage 1 SNAC wrist means the arthritis is localized between the scaphoid and the radial styloid. Therefore, you can consider a radiostyloidectomy plus a scapholunate reduction and stabilization versus a distal pole excision of the scaphoid. Remember, if you're performing a radial styloidectomy, do not excise greater than 4 millimeters for fear of compromising the RSC ligament. In stage 2 and stage 3 SNAC wrists, they have very similar treatment options available, which are dependent upon where along that spectrum of disease they are. For a proximal row carpectomy, remember that requires the capitate to articulate with the distal surface of the radius, and if that proximal aspect of the capitate has become too arthritic, that is not a great choice. However, if the capitate arthritis is minimal, you can either choose to allow the capitate to articulate directly with the distal radius, or you can interpose some capsular tissue. The four-corner fusion and the capitolunate arthrodesis are both viable options because that relies on the lunate articulation with the radius, which tends not to be compromised in the setting of a SNAC wrist. Or you can jump all the way to a wrist arthrodesis if there are additional underlying pathologies to be managing. Going into other carpal, the triquetral fracture is the second most common carpal bone fracture. It comprises 15% of all carpal bone fractures. It is classified as either dorsal cortical disruption, which is the most common, fracture through the body, or palmar cortical disruption, which is a risk factor for instability. The image here depicts the intrinsic and extrinsic ligaments that either originate or insert on the triquetrum. I thought this was just a helpful reminder of all of the different ligaments that are interacting with the triquetrum. Of course, when evaluating for a triquetral fracture, you'll obtain an x-ray. I think the most common x-ray you'll see on an exam will be this lateral image, which depicts the famous pooping duck sign. What you'll have to know is that not only does this image depict a triquetral fracture, but you'll have to know the ligament associated with this fracture fragment, and that is most commonly the dorsal radiotriquetral ligament. Additional imaging you can obtain is either a CT if you're looking for further bony evaluation, or an MRI if you're looking at more soft tissue. Treatment options, most commonly it is immobilization in the form of a cast. However, if it's a larger fracture fragment or there's concern for associated instability, can consider open reduction and internal fixation. Hamate fractures tend to be classified based on location, whether it is a hamate body or a hook of the hamate fracture. The associated conditions listed tend to occur most commonly with hook of the hamate fractures, and they are either a tendinitis or tendon rupture of the small and ring finger flexors as they traverse the hook of the hamate, or ulnar neuropathy, which most commonly is motor, and it occurs in zone 2 of Guillen's canal. The image here is a depiction of Guillen's canal demonstrating the relationship between the ulnar nerve and the hook of the hamate. Next step for identifying hamate fractures is imaging. Below is a picture of the carpal tunnel view. The carpal tunnel view is the best for evaluating a hook of the hamate fracture. The image provided is a carpal tunnel view with an associated hook of the hamate fracture. If you need advanced imaging, make sure that you're getting a 1 millimeter cut of your CT. Treatment options include immobilization, excision, and open reduction internal fixation. If you immobilize these fractures, about 50% of them will go on to non-union. The most common surgical option is excision. Any question you encounter involving an athlete in the hook of the hamate fracture, the option will be to excise that fragment. That allows them to have the fastest recovery and return to play. Complications associated with hamate fractures are non-union. If you immobilize them, 50% of them will go on to non-union. You can also have ulnar nerve neuritis and rupture of the flexor tendons or tendon irritation, secondary to the location of the hamate with the traversing flexors of the small and ring finger and its relationship with Guillen's canal. If those complications arise, take that fracture fragment out. They do mention a weakened grip strength, but it is the option for athletes to excise that, and they have been able to return to play. Another little break slide. We're getting pretty darn close to the end. Now for Kienbock's disease. Kienbock's disease is avascular necrosis of the lunate. Causative factors are ulnar negative variance, decreased radial inclination, repetitive trauma, lunate geometry, or the vascular supply. There are 3 variations of blood supply to the lunate. The 3 variations are depicted below. They are the Y pattern, the X pattern, and the I pattern. It is postulated that the I pattern has the highest rate for avascular necrosis. The Lichman classification is utilized to identify the stages of Kienbock's disease. Stage 1 is findings that can only be found on MRI. Their X-ray looks negative. Stage 2, you note sclerosis of the lunate on X-ray. Stage 3A, you have collapse of the lunate without associated scaphoid rotation. 3B, you have collapse of the lunate, but now the scaphoid has a fixed rotation. Again, scaphoid likes to flex. Stage 4 is lunate collapse, fixed scaphoid rotation, and degenerative changes of the associated intercarpal joints. Kienbock's disease is most common in males between the ages of 20 and 40 years. On exam, they'll have dorsal wrist pain and swelling, decreased range of motion, and grip weakness. For imaging, if you cannot see sclerosis of the lunate on X-ray but you're concerned, obtain an MRI. The MRI is best for early disease diagnosis. It also allows you to look for alternative pathology such as ulnar impaction. The CT is most helpful to determine the extent of necrosis, the associated destruction, and the lunate geometry. I think this table is beneficial for indicating the appropriate treatment for each stage. Stage 1, immobilize and NSAIDs. Stage 2, that means you're seeing sclerosis of the lunate on X-ray. You talk about doing a joint leveling procedure. If they're ulnar negative, you can do a radial wedge if they're ulnar neutral but have decreased radial inclination, or you can talk about a distal radius core decompression or revascularization procedures. Stage 3A means that there's lunate collapse, but there's no fixed rotation of the scaphoid. You have the same treatment options as those in stage 2. Stage 3B means the lunate has collapsed and the scaphoid has a fixed rotation. Again, the scaphoid likes to flex. For stage 3B, you can consider a proximal row carpectomy, an STT fusion, or an SC fusion. And at stage 4, you start to have degenerative changes in the adjacent intercarpal joints. For that, you can consider a wrist fusion, a PRC, or a limited intercarpal fusion. The next slides just show some of the treatment modalities that I don't think we see as often. So here is a picture of a temporary scaphotrapezio-trapezoidal pinning. This is utilized in adolescents that have radiographic evidence of Kienbock's and progressive wrist pain that is non-responsive to immobilization and NSAIDs. In stage 2 and stage 3A, you can consider a revascularization procedure. Here again is a depiction of the vascular anatomy of the dorsal distal radius, and then the attached image is a depiction of the most commonly utilized pedicle bone graft. It is based upon the 4-5 extensor compartment, very similar to the scaphoid non-union that utilizes the 1-2 or the 2-3 intercompartmental artery. We just shift this more ulnarly and it utilizes the 4-5. I thought this table was interesting for its depiction of the percent decrease on the radiolunate contact stress associated with the different treatment modalities available for Kienbock's disease, ranging from 0% to 66%. Now on to ligamentous injuries. This will circle back to some of the topics brought up in our anatomy discussion. When talking about carpal instability, it is important to have an understanding of the terminology utilized. Pre-dynamic means partial tearing of the ligament, but the x-ray is normal. Dynamic means that you can have x-ray malalignment with stress. Static means that there is x-ray malalignment even at rest. Dissociative is a dysfunction of articulation and motion of bones in the same carpal row. Non-dissociative is dysfunction between the carpal rows or between the carpal rows and the radius. And then complex is a combination of dissociative and non-dissociative instability. First, we'll address SL ligament injury. SL ligament injuries most commonly occur with the wrist position and extension and ulnar deviation and the carpus supinated. Remember that with the wrist extended and ulnarly deviated, that the scaphoid is in an extended position. Thinking back on our anatomy talk, the dorsal component of the SL ligament provides the greatest constraint to translation between the scaphoid and the lunate. When that is injured, it allows for SL joint widening. When obtaining x-rays, that widening is known by the nomer of Terry-Thomas sign. This is the gap between the scaphoid and the lunate. An additional sign you can see on x-ray is called the ring sign. It not only shows SL joint widening, but it demonstrates this ring appearance of the scaphoid secondary to scaphoid flexion. Remember that a knowledge of your bony landmarks will help you elucidate and localize a patient's area of pain. And here is a redepiction of the SL ligament provocative test, the Watson shift that we had previously talked about. If an SL ligament becomes chronic, it can lead to a DISI deformity. DISI stands for dorsal intercalated segmental instability. That is a dissociative instability. Dissociative instability means that it occurs within the same carpal row. It is the most common dissociative instability. That is identified on the lateral x-ray, and what you're looking for is the scapholunate angle. And so you put a line down the axis of the lunate and a line down the axis of the scaphoid and measure it as depicted here. If it is greater than 70 degrees, that is indicative of a DISI deformity. Remember that when the SL ligament is injured, the scaphoid naturally wants to flex. It will do so. That leaves the lunate connected to the triquetrum, and the lunate will follow the triquetrum and extend. If a DISI deformity is not treated, it can go on and progress to a SLAC wrist. SLAC stands for Scaphoid Lunate Advanced Collapse. Below is a depiction of the Watson classification for a SLAC wrist. The Watson classification traditionally involves stages 1 through 3. Stage 1 is arthritis between the radiostyloid and the scaphoid. Stage 2 builds upon stage 1 and involves the proximal radioscaphoid articulation. Stage 3, again, builds upon stage 2 and involves the scaphocapitate and lunocapitate articulations. With Watson's classification, you'll note that there is preservation of the radiolunate articulation. There are some subsequent surgeons that have advocated for a stage 4 to include pancarpal arthritis. However, this is controversial, and the presence of a pancarpal arthritis should alert you that there could be a different underlying etiology of this patient's arthritis. There's a spectrum of treatment modalities available for SL ligament injuries. If pursuing non-operative management, that involves NSAIDs, rests, and plus or minus immobilization. More often than not, we're considering operative intervention. The first step to determine which treatment modality is to assess for carpal malalignment. Remember, when an SL ligament is injured, it allows the scaphoid to flex and the lunate to extend. When the scaphoid flexes and the lunate extends, that allows for formation of a DISI deformity, which is identified on a lateral radiograph and has a scapholunate angle greater than 70 degrees. Additionally, because the scaphoid flexes on an AP image, you can note the ring sign, which is representative of scaphoid flexion. If this carpal malalignment is reducible or there is no carpal malalignment noted, you can proceed with either an SL ligament repair or a reconstruction. If there is additional pathology associated with your SL ligament, such as a scaphoid fracture, you need to proceed with scaphoid operative management. As we had previously talked, there is a very limited window for non-operative indications, such as less than 1 millimeter displacement. Now, if imaging reveals a rigid and irreducible deformity, you need to proceed with stabilization in the form of a wrist fusion, which can either be a scaphotrapezial trapezoidal fusion or a scapholunocapitate fusion. If your SL ligament injury has progressed to a SLAC wrist, then it's important to note the Watson classification associated with the patient's SLAC wrist and the patient's symptoms. As with any arthritic entity, you can consider non-operative management in the form of NSAIDs, splinting, plus or minus use of injections. For operative intervention, that is driven by the Watson classification. If they are a stage 1, where it's arthritis between the radial styloid and the scaphoid, you can do a radial styloidectomy. Again, do not take off more than 4 millimeters for concern of damaging your RSC ligament origin, combined with a PIN and an AIN denervation. If it's stage 2, meaning that it has not only involved the radiostyloid, but the entire radioscaphoid articulation, you can do a proximal row carpectomy or a scaphoid excision and a 4-corner fusion. A stage 3, you can consider a scaphoid excision and a 4-corner fusion or a wrist fusion. You can't do the proximal row carpectomy because the proximal aspect of the scaphoid the proximal aspect of the capitate has been compromised. Now for lunotriquetral ligament injuries. Harkening back to our anatomy discussion, the volar aspect is the thickest and strongest portion of the LT ligament. And in order for a VC deformity to form, there has to not only be injury to the LT ligament, but there also has to be disruption to the dorsal radiocarpal ligament, otherwise known as the dorsal radiotriquetral ligament. These entities are displayed in the images below. LT ligament injuries tend to occur with the wrist hyperextended and radially deviated. The images below demonstrate the LT shuck test or ballottement test, seen here, or the Kleinman shear test. Those were previously discussed in our physical exam section. Again, it's just important to be able to identify your superficial anatomy in the wrist to help you localize the area of pathology and to help you appropriately perform these provocative maneuvers. This slide is a representation on how to measure the scapholunate angle and the capitolunate angle. The previously discussed scapholunate angle is determined by drawing a line down the central axis of the lunate and an additional line down the central axis of the scaphoid. The corresponding angle is your scapholunate angle. An angle greater than 70 corresponds with the DISI deformity, and an angle less than 30 corresponds with the VC deformity. The capitolunate angle is found by drawing a line through the central axis of the lunate and a secondary line through the central axis of the capitate. A normal angle for that is between 0 and 30 degrees. Chronic LT ligament injuries, when combined with injury to the dorsal radiotriquetral ligament, can lead to the development of a VC deformity. VC stands for volar intercalated segmental instability, which is a form of dissociative instability. Dissociative means that it occurs within the same carpal row. How do we identify this? On X-ray, you'll be looking for your scapholunate angle. A VC deformity is consistent with a scapholunate angle less than 30 degrees. This occurs because of the disruption between the lunate and the triquetrum, which allows both the lunate and the scaphoid to flex. You will also be looking at the capitolunate angle. You can compare between sides and you'll note an increase in greater than 15 degrees. Management of LT ligament injuries. For non-operative management, we will observe these patients. For patients pursuing operative intervention, if there is acute instability, the patient can undergo closed reduction and percutaneous pinning with acute ligament repair plus or minus dorsal capsulodesis. In the setting of chronic instability, lunotriquetral fusion can be performed as demonstrated in these bottom images. And in the setting of chronic instability with ulnar positive variants, the patient can undergo debridement of the LT ligament with associated ulnar shortening. Now for perilunate dissociation. Perilunate dissociation is a commonly missed entity. Approximately 25% of them are missed on initial presentation. How does this injury occur? It generally occurs with the wrist extended and ulnarly deviated with associated intercarpal supination. There is a sequence of events that occurs. It begins with disruption of the scapholunate ligament, followed by disruption of the capitolunate articulation, then the lunotriquetral articulation, failure of the dorsal radiocarpal ligament, and then ultimately the lunate is able to rotate and dislocate, usually into the carpal tunnel. The dislocation course can either occur through the greater arc, which involves not only ligamentous disruption but associated fractures, or the lesser arc, which is a purely ligamentous injury. So there are two categories for dislocation. It is a lunate dislocation, where the lunate is forced either volar or dorsal while the carpus remains aligned with the distal radius, or a perilunate dislocation, where the lunate stays appropriately positioned in the lunate fossa and the carpus dislocates. In the setting of a perilunate dislocation, there are four types. There is the perilunate, the transscaphoid perilunate, the transradial styloid, the transscaphoid transcapitate perilunate. The Mayfield Classification is a staged representation of the sequence of events previously noted. Stage 1 is scapholunate dissociation. Stage 2 is stage 1 plus lunocapitate disruption. Stage 3 adds lunotriquetral disruption. And stage 4 represents the lunate dislocating from the lunate fossa. Most commonly, it dislocates volarly. When it dislocates volarly, approximately 25% of patients will have associated median nerve symptoms secondary to the lunate's position within the carpal tunnel. How do we reduce these? The reduction technique demonstrated here is utilized for Mayfield stage 4 dislocations, where the lunate is located within the carpal tunnel. The key to this technique is muscle relaxation and prolonged traction. Best for prolonged traction is to get them up in finger traps, allow some weight to hang off the arm, and give it time. Once you think you have allowed for sufficient muscle relaxation and prolonged traction, you then provide additional traction while extending the wrist. Utilizing your other hand, you will place pressure on the lunate and then slowly bring the wrist into flexion. How do we treat these? Non-operative management in the form of closed reduction and casting. There is no indication for this to be definitive management. There are universally poor functional outcomes with definitive non-operative management, and recurrent dislocation is common. Operative treatment options for acute injuries less than 8 weeks old. The reason they're separated is, remember, approximately 25% of these are missed on initial evaluation. If we find these acutely, they can undergo emergent closed reduction and splinting. That's in the setting of patients that have associated median nerve symptoms. And then in an urgent fashion, they can undergo open reduction, ligament repair, fixation, and plus or minus a carpal tunnel release. Following operative management of these injuries, it is very common for these patients to have decreased grip strength and stiffness. If it is a chronic injury, meaning greater than 8 weeks from onset, patients should undergo a proximal row carpectomy. And if there are associated degenerative changes, the patient is best suited with a total wrist arthrodesis. The images provided here demonstrate a lunate dislocation. The reason it's classified as a lunate dislocation is because the lunate is not within the fossa. If the lunate was within the fossa, then it would be a perilunate dislocation. Images B and C demonstrate the intraoperative findings followed by the postoperative stabilization, and image D demonstrates the patient 8 months after injury. The last thing we will briefly touch on is transient ischemia of the lunate that can occur after dislocation. This is a radiodense appearance of the lunate on X-ray that occurs in about 12.5% of cases. It's typically identified 1 to 4 months post-injury. It's important when you see this to not jump on that this is AVN. Transient ischemia of the lunate is a self-limiting and benign process, so we just observe these patients. Here are my references. That was a long presentation. I appreciate your patience and attention. Hopefully you were able to take something away from this. Thank you.